Hello, everyone. Welcome to OBHealthy's Doctor Lounge. All righty. We're a group of Black physicians, and we're here for two basic reasons. Hold on just for a second. Okay. I have to say, okay. We're here for two basic reasons. Number one is we're here to improve the health of people of African descent. And number two, to encourage young Black males to go into medicine because believe me, we need you. So if you're a young Black male out there, even thinking about medicine, think hard, think long, but go ahead and dive in because your people need you. And that's all I want to say about that at this particular point. Our webinar is every second Saturday at 1 o'clock. And it's so easy to join this webinar. You just go to obhealthy.com, click on the doctors tab, and just register in and come and be a part of our webinar. And please let friends and family know about it. It's very, very important that we hold on for a second. And it's very important that we, just keep things alive as far as health in the African American community. All righty. If you want to look at our past webinars, all you have to do is go to OB Healthy and just look at the YouTube channel. All of our past webinars are on YouTube, many different medical topics. Check them out. Education is so important when it comes to your body and keeping it healthy. All right. Remember to subscribe to the YouTube channel so that we can continue to bring this to you. All right. The most important thing that I can say today, the most important thing is please do not change any aspect of your medical care until you consult your physician. Only your doctor, believe me, only your doctor can truly take care of you from a medical perspective. All right. What I'd like to do is I'd like to let the docs introduce themselves. Our topic today is breast cancer. And we got the sister in the house, sister in the house. Let me tell you, we are going to jam this topic. All right. But before she goes on, I want the two docs that are here with me right now to introduce themselves. Then I'll have her introduce themselves and understand we have doctors that will be signing on as time goes on. They're in the hospital rounding right now, but as soon as they're finished, they will come and join us. All right. Dr. Sprock, can you introduce yourself, please? You're on mute, Doc. Dr. Sprock, you're on mute. There you go.
Okay, I'm Dr. Kendall Sprott, retired board certified pediatrician. I did 15 years of pediatric critical care as well as general pediatrics, and I'm happy to be here.
All righty. Dr. Jordan Garrison, please.
Good afternoon, everyone. My name is Jordan Garrison. I'm board certified general surgeon, bariatric and vascular surgeon, practicing venous medicine now in Hackensack, New Jersey. But of note, when I started my practice as a breast surgeon and practiced breast surgery for 10 years. I ran a program called In the Pink, which was an early detection and awareness program out of St. Michael's Hospital, where we uh, gave free breast care to any woman that came in, free mammograms. We even had a program where we do uh, surgical interventions, and if we needed reconstruction, we were able to provide reconstruction for the patients as well. So I'm interested in hearing your talk, and hopefully I can add a little something or learn a lot. Okay, I'm going to stay in the posture of learning. Thanks for coming.
Thanks.
All righty. And Dr. Janet McDermott, um, you are a phenomenal breast surgeon. Believe me, I know personally, and I am just so appreciative that you'll come and join us and talk about this topic that's actually so prevalent in our communities. But first, let's just step back for a minute. Tell us about who you are. You know what I mean? Where'd you come from? Where'd your people come from? Tell me something about Dr. McDermott. All righty. Just say hi to us.
Hi, guys. So, I'm a transplant. So I'm originally from Jamaica, and I came here to go to college and stayed. And basically, I started out in the Northeast, and then went to Texas because I thought the Northeast was too cold. Stayed in Texas for a while and then went on to Chicago to do a surgical oncology fellowship. And subsequently, after my fellowship, moved back to Northeast because I realized that the politics and the temperament in the South was not for me, despite them offering millions of dollars. I didn't want to be an abnormality or something for everyone to point to. So I got back to the Northeast and I was doing surgical oncology initially out of Fox Chase. And then one of my professors from Columbia reached out to me and said, hey, you want to come do breast? So for 2 years, I said, no, I don't want to come do breast, because I want to do livers. I want to do these big cases. It turned out that after about 2 years saying that I didn't want to do that, I decided to move to North Jersey and basically, specialized in breast cancer, because when the more north you go, everyone is subspecialized. And 70% of what I did anyway was breast, doing surgical oncology, and lifestyle was great. Intellectually, there's more about breast cancer than any other cancer, so you'll never get bored intellectually. And lots of trials, lots of options. And I just thought it was such an epidemic for our people that it was worth me, subspecializing in that. I've been doing that for a long time.
Excellent, excellent. Well, we're so appreciative. Believe me, we are. I'm going to step back because we have quite a bit of audience that's joined us already. Let's just start off basically. You know, and I really mean really basic. What is cancer? I mean, this word pops out all over the place, but tell me what cancer is.
So, I mean, like I like to tell my patients is this. So, you're born, every day your DNA does work to get you through your day. Okay. It's the process by which the cells, reinvent you every day. And as you get older, basically what happens is that the number one cause of death is going to be cancer as we all get older, because our cells age as we get older. Okay, which is why longevity medicine is such a big deal these days. And as we age, our DNA makes mistakes. So we've got a normal cell. As we're aging, we're building up inflammatory processes in our body. It impacts on our cells. We age, we get some abnormality. It's not recognized because it doesn't show up on a mammogram, doesn't show up on colonoscopy, doesn't show up on any screening test when you just have abnormalities. And then if that's not caught, then that then goes on to become cancer, because now your immune system is not as active as you get older. And we're depending on our immune system to get rid of the DNA mistakes. So if it's not getting rid of DNA mistakes because it's aging just like our body, then it's going to evolve into cancer eventually. So it is sort of the natural process that our bodies are going to go through for the most part, impacted by genetics. But genetics can load the gun, but lifestyle is essentially what pulls the trigger. So you don't have to manifest your genes. And so it is an expected part of the normal process, but there are ways that we can impact on it.
Mm-hmm, mm-hmm. Yeah. Interesting. What it also is, and we're going to talk about Black people just for a minute here.
Mm-hmm.
As far as Black females is concerned, is it more common in our neighborhoods than in other cultures?
It is.
Mm-hmm.
And the interesting thing is that it's not under the age of 45. Breast cancer is the most common cancer in African Americans or anyone from that African diaspora. So whether you're Latino, whatever it is. And that has to do with the fact that the type of breast cancer that we see in our under 45, African ancestry is based on what we see in Ghana, Nigeria, and those other places. And that's basically the whole slave trade, the transatlantic slave trade route. Mm-hmm. And breast cancer is not what we see as more common as we get older among the African American group. I mean, so breast cancer is more common over the age of 65 in Caucasians, but for us, we see it more commonly at a younger age because of some of those, translational changes that we see coming from Ghana and Nigeria and sub-Saharan Africa, as well as some of our lifestyle choices. And so as we are getting more overweight, less active for whether it's based on, generational trauma or the things that were done to us when we came to this country, we are definitely seeing an impact. And our mortality rate is definitely, even though it's not, even among our over 65, our mortality rate is significantly higher than the Caucasian population, despite them having a higher incidence over 65.
Interesting. You know, I look at stress, even from a critical care and from a pulmonary standpoint, as far as stress is concerned. And there's so many life stresses that we as a culture have to endure. Do you think that is part of why some of our medical problems are just so keen in our neighborhoods?
Absolutely. I tell people all the time the two initial risks for breast cancer is going to be gender and then age. The other three factors that impact on your risk, which impacts on your risk 85% of the time, because only 15% of breast cancer is genetic, is one, your body weight relative to particularly waist to hip ratio, because it's truncal body fat that's important. Two, lack of activity, not necessarily exercise, to get rid of inflammatory traces. And three, which is probably the most significant, would be stress, because a lot of what you're right, we're dealing with a lot of stress, and we know stress is not going to go away. But what we have to learn to do is what I call emotional regulation. We cannot react to every stress. We have to learn to make that stress a productive force in our life and not, internalize it and increase the inflammatory process, because there have been a lot of studies that have shown that when you look at inflammatory markers based on stress levels, it impacts everything that happens to you from a chronic disease as well as a cancer standpoint.
Interesting, interesting. Also, as far as our people and screening, all right. How do and there's so many times, and I know the other doctors probably have this as well, that a patient will need to be dragged into the office to get the appropriate test or the screening. And how do you handle that from your perspective? Just convincing our patients to come in and say, you really should be screened early because of our history and the chances of it happening to us as a people in a culture. How do you handle that?
Well, I mean, I think first of all, like I tell everybody, you have to realize that no one's going to care about you like you're going to care about yourself. And at the end of the day, you have to value you and realize that no one is going to validate you. So if you realize that, your health is important, it is what's going to maintain and keep you, whatever, I have people like, I've got this high power job, I can't take time off. Well, where are you going to be if you're not alive for the high power job? I have all these family obligations. You can't support anyone if you don't support yourself. So it's important to realize that a lot of times there's a lot of fear involved with not wanting to be screened, because there's a lot of media play about breast cancer. But the fear should not keep you from taking action, because what that fear does is really have us get diagnosed at a later stage when we have less options. And sometimes, depending on where you are, given no options at all. Because breast cancer care, like most care, is regional in this country. I mean, geographically, what you're going to get in the Northeast is not necessarily going to get in the Southwest, or not you're going to get in the South or other areas. So it's important to realize that you need to say to yourself, listen to your body. Don't let anyone tell you that, the studies or whatever, we're not going to screen before 40, because we see it in younger patients before we're screening. So if you feel something is wrong, something, you need to persist, be your own advocate, and do not let fear paralyze you.
Excellent, excellent. I see Dr. Jordan Garrison has his hand up. Jordan, you're on.
Hey, I beat Kendall to the punch today. Listen, I really am appreciative of you talking the sociology and of this before you got into the medicine. But you did make one statement, and I'd like you to elaborate on it, where you talked about things lifestyle changes. You talked about supplements that decrease inflammation and things like that. Could you elaborate a little bit more? And my question really is, so if I change my lifestyle, is that going to prevent me from getting cancer?
So in reality, nothing is 100%, right? But honestly, we know that basically, even if I have patients that have, a high risk gene, and you have options these days because we know that we can personalize treatment. So even if you have a high risk gene for any cancers, okay, and you know that based on family history, you don't have to manifest that because basically there's other things. It's all a chain reaction, right? So even if you have the gene, you're higher risk, that doesn't necessarily mean you're going to get breast cancer or you're going to get any cancer for that. So yes, lifestyle changes will impact on whether or not you get it. There's certainly people with no risk are going to have breast cancer or any cancers. But the truth is that if you're in the best shape of your life, then you're able to get everything. So there's no 100% like I did everything right, I'm never going to get it. But at the same time, if you practice the things that are going to modify those things, you're going to be found at an earlier stage. You're going to be more curable, more treatable, those kind of things, because these things do impact on what happens to you. And that's the bottom line. So what do you change? Well, alcohol. The Surgeon General just added alcohol to all types of cancer, but we've known that alcohol impacts breast cancer because a lot of times when I see male breast cancer, I ask them a couple of things. One, what's your alcohol intake? Because hormones get estrogen, alcohol becomes estrogen in the liver. It affects all the metabolic systems, that kind of stuff. Alcohol, one thing that we need to change, right? There's no safe drinking, whatever. Then we need to change things like the inflammatory foods like dairy. Nobody over the age of 2 needs to be ingesting anything that's dairy because dairy is highly inflammatory over the age of 2. You can get everything you need plant-based and eating all the right things. And that's why 70% of the world is lactose intolerant. Your body is smart. It gets rid of what you don't need. But people basically just adjust whatever they can and take whatever makes them feel good. Okay, Sugar is highly inflammatory under any situation, whether it's fruit sugar or regular sugar. Your body handles it the same way. So at the end of the day, you get rid of the things that increase inflammation in your body, and you have inflammatory markers that you could check. And you could see how when you modify what you're eating or your lifestyle, how those inflammatory markers go down. And activity. It's not about exercise because even if I get up and ran 10 miles before I went to work, if I sit for more than 30 minutes, I'm building up inflammatory markers. I need to keep moving, which is why people in the blue zone, they've never jumped on a Peloton, they've never done marathons, but they live to be 100, cognitively intact, running their own business, doing all these things. So yes, lifestyle impacts a lot. And a lot of my people with high risk genes that decide not to do, prophylactic surgery, I'm following them for 20, 30 years with change of lifestyle, and they're doing great, still have not manifested their cancer. Mm-hmm. And if they do, it's early because I'm screening them.
Mm-hmm. What about the impact? We now have come to the age where marijuana smoking is legal. Mm-hmm. So people think it's safe. Can you make, I know it increases gynecomastia in men. Could you elaborate on that?
So essentially, gynecomastia in itself does not increase your risk for breast cancer because we see a lot of gynecomastia in general. I mean, idiopathic, that kind of stuff. But at the end of the day, and we see it for men taking hormones for their, prostate cancer treatment, as well as people on, cardiac drugs, digitalis. And a lot of I see it too on some of the GLP-1s. Januvia, those kind of things. So it is not that uncommon these days. But honestly, when it comes to marijuana, there is no data right now that says that marijuana increases your risk for breast cancer because we don't have, the data are still immature, right? So we're looking at it, but it hasn't matured enough for us to say yay or nay. But yeah, I mean, the point of the matter is that we know that any type of smoking changes the duct lining of the breast, and that increases your risk for cancer. So I think in the future we're going to see some of that from the marijuana story, but it's too immature.
Mm-hmm. Mm-hmm. All righty, Dr. Sprock, your hand.
You mentioned several things that might be related to inflammation. that then might be a contributory factor towards breast cancer and other types of issues. And so, despite the fact that there've been lots of treatments that have been developed for breast cancer, and been a lot of emphasis on trying to detect it early. One of the things, in pediatrics, we always think about and talk about is prevention, which is why we like vaccines, because I've seen the tremendous impact in terms of elimination of a lot of deaths and damages from a lot of both bacteria and viruses that used to, you know, have us with 20 admissions a night from infectious diseases kinds of things. But one of the things that I've always wondered about is whether or not if you were to take anti-inflammatory drugs or supplements or foods or antioxidants, whether or not that might help in a preventive way that might minimize some of the risk associated with inflammation that might be a trigger or a factor in the development of cancers.
So, there's a lot of studies on NADs, which are, considered anti-inflammatory. But the point of the matter is that when you start taking these things that they're usually put together with other, other things that aren't necessarily good for you. So my thought, my personal thing is when people ask me, should I take supplements? Should I whatever? I think of supplements a lot of time as expensive pee, right? You're spending a lot of money for these supplements. And my thoughts are that if you're eating right and making sure that you're eating the things that are anti-inflammatory, then you shouldn't need to spend money on supplements. So I think that if you do your research, I mean, there's certainly a lot of stuff, a lot of food out there, and your body, like I said, it's smart. It takes what it needs and gets rid of what it doesn't need. When you're buying stuff with, all the other preservatives, all the other things that we can't even call the names for, then you're actually putting yourself at risk for other things too. And that's why I'm not a big supplement fan, unless you can actually say, I'd rather you eat mushrooms for all the anti-cancer effects, although you can't eat enough. But if you add in, do it on a daily basis, you're going to get the benefits. Just like, they talk about resveratrol for grapes. You'd have to put your whole body in a tub of grapes for it to have the same impact or whatever it is. But I mean, over time, it's all cumulative. So I'm a fan of eating the things that are antioxidants. I'm a fan of eating the things that are anti-inflammatory instead of spending money on things. And when you're eating that way, you're going to eat healthier, and your body's going to do what it needs to do and what it's been primed to do, as opposed to taking a lot of supplements, that aren't necessarily, you're spending money and getting minimal benefits from it.
Mm-hmm. Excellent. You know what I'd like to talk about? I'd like to talk about just the breast cancer, but where in the breast? I mean, give us an understanding of how the breast is put together, number one. And number two, where cancer is usually located for our people.
Okay. So I like to tell my patients, I think of the breast like looking at, say, a tree, right?
Mm-hmm.
So basically, you've got three main components in the breast. You've got the fatty tissue, okay? Basically, that would be, the area surrounding, say, if you're in a forest with the trees. Then you've got the ducts, which I think of like the branches of the tree, okay? So the tubular portion. And then you've got the leaves, which I think of as the lobules of the breast. Okay. So if you're thinking about the breast in general, the leaves, the lobules are where the milk production gets done in a pregnancy. And then, you get the contraction from the hormonal stimulation. It comes down into the branches, okay, the ducts, and they all get together at the main trunk, which would be your nipple, right? So that the baby can then, get nutrition. Most breast cancer will originate in the ducts, okay? And then the second most common area will be in the lobules. So what I call the garden variety breast cancer would be invasive ductal breast cancer. And the less common would be invasive lobular, which would then originate in the leaves if you're thinking of, a tree per se. And basically, we know that the importance of the lobular breast cancer is it tends to be multifocal in more than one areas of the breast that it's in. And it could be bilateral relative to the ductal breast cancer, which usually only in one area of the breast. So the type of breast cancer sort of tells you what type of workup you need to do before moving on to the next step. Does the patient need an MRI? Or, possibility of multifocality, having it in more than one area, having it bilateral in both breasts. So that's how I use that information to determine my workup before I determine what our next steps are.
You used a word that many may not know what it means. It's called, and you said invasive.
Right.
Explain what you mean by invasive.
So we talked about how we get cancer. We talked about a normal cell, then having a DNA mistake, it goes on to be abnormal. And then the next step from the abnormal in breast cancer would be in situ breast cancer, which is breast cancer that is contained within the walls of the duct. So if you think of like maybe a straw in some liquid, the breast cancer that is in situ would be contained within the walls of a straw, would not have gone out into the milieu of the liquid, right? So that's an in situ stage 0 breast cancer, which is the earliest possible form of breast cancer. That cannot go to lymph nodes. It is 100% curable for the most part. And that's why mammography and microcalcifications, we try to get that before it goes on to become invasive. Okay, so now what is invasive? Invasive is when that cancer is breaking through the walls of that straw and is now invading the fluid or the milieu that is in whatever glass or cup or whatever the straw is in. So for the breast, that would be involving the fatty breast tissue. So it's outside of the duct and it's now inside the fatty part of the breast, the parenchyma.
Right. I understand. So it's gotten outside of that initial area.
Yes.
And it's invading and going into other areas of the breast.
Mm-hmm.
Let me just take a moment and the audience out there, what we need is questions. We need your questions. I don't see any questions coming up. We'd love to answer any questions that any of the audience out there that's listening to us. Please post your questions so we can get them answered and we'll move forward. But don't be shy. I know sometimes you're listening and you're like, oh man, I'm listening to a doctor. I don't know if my question is good enough. There's no question too small, none too large. We will try to answer at the best of our ability all of your questions. All righty. Talk about survival for me. The thing of it is that anytime you say cancer, boy, I'm telling you, you're talking about the sweat beads start popping out. What's the likelihood with the many patients that you see that when someone walks into your office that they're going to be okay?
Well, I would say this is that if I'm going to get to choose my cancer as I get older in life, I tell people all the time, breast is what I'm going to choose. And stage for stage. And I say that because honestly, the reason why there is so much media play around breast cancer is because these are all survivors that are advocating for treatment trials, that kind of stuff for the most part. So if you look at all breast cancer as one, breast cancer is highly survivable considering that you're doing all that you need to do, so it's diagnosed early. But even when you diagnose breast cancer at a later stage, based on the characteristics, we can make some of the most aggressive breast cancer now chronic disease, just like we treat diabetes, high blood pressure. So certainly the most common type of breast cancer, the ductal, is divided into two subsets. One is highly curable, but it's also the one that will come back 20, 30 years from now based on lifestyle, right? The other one is a little bit more aggressive, also highly curable. And then there are two other subsets of breast cancer that tend to be more aggressive. And I would say 10 years ago, one of the subset of breast cancer that tends to be more aggressive would be a death sentence. But we've come up with basically ways to use our own individualized treatment. So we've got basically used immunotherapy. which is using our immune system to be able to fight that type of breast cancer, where we can have somebody present with an advanced type of breast cancer that would have been a death sentence 10 years ago, that person can now have a long life and good quality of life. So not just long life, but good quality of life, although they're maintained on medicines for their stage 4 breast cancer. I mean, for 10, 15 years, and with no progression. So we've come a long way with immunotherapy and being able to do precision medicine. I mean, in terms of the more aggressive type of breast cancer that we see in African Americans, we're making gains, not as much as we want to, but it's important to be able to get all the information about the individual treatment to be able to do individualization of that treatment, because that's going to impact on the person. It's not one size fit all anymore. So it's important that you go to people that have knowledge of all the new and cutting edge technology, because it's going to impact on how you're taken care of.
Oh, excellent, excellent. We're getting some questions that are coming in, but I know Dr. Sprott has his hand up. Let me get to Dr. Sprott, and then we're going to take some questions, okay? All right. Dr. Sprott, go ahead, please.
You touched on a topic that I'd like for you to spend a little more time on, because you talked about the issue of cancers arising from normal cells. So when you talk about the ducts, the cells that make up the ducts within the breast are normal. And many people believe that cancer cells will arise from normal cells, maybe due to some insult or some exposure to a virus or something toxic that changes the surface of the cell, but within the cell causes those cells to divide faster than normal. And a normal immune system and certain types of white cells might recognize the abnormality of the cell and take it out. And so preventing cancer cells from reproducing and developing and spreading. And some people believe that there's a failure of the immune system to be able to recognize these altered cells, which allows them to sort of spread and grow. And one of the questions I have is whether or not there are things that you might be able to do to sort of help or aid the immune system to start to recognize these cells and take them out. And I know that in certain cancers that have been more related to viral infections, that they can sort of take those viral particles, if you will, that they think may be part of the mechanism by which cancers arise, and specifically develop, I'll call them killer white cells, that specifically are now developed, and the only thing that they go out and destroy are the abnormal cancer cells. And so you don't have the kind of side effects from typical types of medications used in cancer, either chemotherapy or radiation therapy, that sort of blindly destroy cells that are developing rapidly, especially those that might be normal cells, which is why you might have GI problems that recur after you are taking chemotherapy or radiation therapy, or if it's specific areas that radiation is involved, you have changes that occur there, because they sort of indiscriminately destroy normal cells as well as the cancer cells. So is there any advancements or things that might be done to try and improve the immune system in general to try and go after these cells that are abnormal, or whether or not there are specific things that have been developed to look at specific types of breast cancer where you create these killer T cells that are silver bullets that only go out, seek and destroy the cancer cells?
So there are things that are going on currently to try and do that, which is why actually there's a very exciting trial that's been going on for the past, I would say, 5 years. And it started out as I Spy 1, which is where we started pitting people with the best cancer with like new novel treatments. That includes vaccines for breast cancer. And then you try to see what's our currently best treatment against these novel treatments. And so things change every like 3 to 4 weeks. So nobody gets a sugar pill. And we don't keep you on this chemotherapy for 12 weeks that's not working, because we're constantly evaluating you as an individual. And so the I-SPY 1 trial started 5 years ago. And now, because it's so successful, we're able to kick out drugs that weren't good, that were targeted therapy. And now we went to I-SPY 2. Now we're in I-SPY 3, and we're able to determine vaccines, and there's vaccines in the trial. The whole idea of the vaccines is to be able to figure out a targeted way to find, just like, vaccines for melanoma, to find these breast cancer cells and take care of them. We're injecting the vaccines directly into tumors at this point, and then seeing the response and basically determining who's getting response. And if they're not getting a response, and we move them to the next best thing or the next new novel drug. So there's a lot going on. Data still is not 100%, but in 5 years, we've been able to weed out some of the things that are not effective. And all the updates from these I-SPY trials have been really, really encouraging. And some of the stuff that we're seeing for the triple negative breast cancer, which is the most aggressive, what we see in our population, has been really encouraging. So yes, we are moving in that direction. It's not all out there yet, but certainly I would say within the next 3 years, we're going to see data that's matured from this, because we're hoping that it doesn't become an I-SPY 4. We think that 3 might be the endpoint for it. We'll go to say these vaccines are something that can target directly, and we're tagging the cells, and we go from there.
So just one other thing, and this is, I'll say a public service announcement, if you will. And that is that one of the areas that is being explored is the use of white cells of people that are anagenically similar. And one of the things that is possible, just like, you have people that can do blood transfusions if they have the same blood type and other things like that. Well, it's something like that in terms of these killer white cells, if you will. That if you're of the same antigenic type, you might be able to get killer white cells, an infusion from someone else that might have these killer white cells that are specifically developed against things like cancer cells or viral things like that. One of the issues that becomes important is to have people in the African American community have the kind of antigenic testing that's needed for transplantation. The same thing might be available for white cells that might be used for cancer. And as these studies start to expand, it might be important that there's a large Black population that might be identified as having similar antigenic types. But unless they get involved in studies just to determine that there might be issues that might inhibit the ability of Black folks to benefit from some of these therapies.
Yeah. All right. Excellent. The thing of it is that we as a people got to become more involved in studies, I think. And I think that way, when medical therapy comes out, whatever that therapy may be, medications or surgical, or like you were talking about, the killer white cells, we know how we'll have a better understanding on how it affects us as a people, and whether we will get the same benefit as the studied population. So that's so important as
Because
well.
Omar, one of the things that we talk about with sickle cell, for example, is one of the cures might be a bone marrow transplant. Well, you need to have people other than people in your family that might be donors, and unless you become part of a group where they actually do that type of typing, then the number of donors that might be available is going to be small, but could be greatly expanded by people just knowing what their antigenic makeup is.
True.
And to that point, there is actually a group of Black breast surgeons that are actually doing work on that. So Lisa Newman out of Cornell right now is spearheading a huge group of, people with similar, ethnic backgrounds, our people in general, and she's getting that tissue and blood banking from, people, African Americans in different metropolitan areas of the US, as well as in Africa itself, because we share some, clearly we share some things. So there is a lot of work going on right now with tissue and blood banking for specifically that reason.
Excellent, excellent. I see that Dr. Court has joined us. Hi,
Thank
Dr.
you.
Court. Can you introduce yourself, please?
My name is Dr. James Court. I practice in East Orange, New Jersey. My specialty is internal medicine.
All righty. You have your hand up, Dr. Court. Did you have
Yes.
a question?
Yes, I do.
Go ahead.
For the doctor, what does she think is the leading cause of development of breast cancer? Is it inflammation? And if so, are there any studies being done? Lots of work going on to counter this?
I definitely think inflammation is your number one cause. I mean, and basically, so the studies, there's a lot of money being done put right now into decreasing. So we know that people that have breast cancer, subsequently what happens to you over time after having had breast cancer depends on lifestyle changes, right? So basically, there's a lot of money that has been put into changing and monitoring to see how this directly impacts. So we know if you gain weight after you get hormone responsive breast cancer, or basically you were overweight and you don't lose any weight, your chance of having recurrence and dying of your disease is a lot higher than someone who adjusts their lifestyle. That's been well documented for a while, but nobody's really put any work into that. But now that there's a lot of work being put into prevention, right, by different foundations. So they're looking at inflammatory markers. In fact, one of my colleagues down at CINJ has a big foundation from the V Foundation, so a big grant to look at checking inflammatory markers on the patients already diagnosed, and then doing lifestyle modifications and checking the markers, how they change, and see how that relates to their subsequent risks. They're following them for 10 years, 5 years, 10 years, 15 years, because that's when we start to see recurrence rates and that sort of stuff. So yes, there is work being done into that, and specifically around inflammatory markers.
Excellent.
Would something like, say, 81 milligram of aspirin a day help?
Well, it's funny because that whole aspirin thing, we used to think because cancer has increased vasculature and that sort of stuff, there was a question of whether or not there was any benefit to using any of those. I mean, so, that was the Avastin story, try and get rid of, decreasing the vasculature, that kind of stuff. And that didn't work. So it's not clear that the aspirin is one of the things that's going to help in terms of decreasing inflammation. That's not something, with all the other possible effects that's widely out there. But I mean, basically, they're focused more on things that are related to lifestyle, that are easy in terms of what you eat, activity, that kind of stuff, and stress reduction, as in terms of whether you incorporate things like yoga, exercise, that kind of stuff in their life, because they're not trying to add something with additional side effects.
Excellent, excellent. We have quite a few questions that have come up. Let's get to some of the questions. Number one, it states that. Hold on for a minute. Let me read this. Kindly comment on exposure of breast to radiation of mammography. Okay, especially young breasts. Will ultrasound be better to use for the young women? Can mammography be alternated with ultrasound from 1 year to another for screening older women? So these are multiple questions in one. And what about MRI?
Okay, so basically, first of all, I want to say this. It's important for people to do what I call risk assessment by the age of 25. Okay, because that really is what's going to determine how individuals need to be screened. Screening is not a one and done. Everything is not for everybody. So all those modalities that we just talked about has a place, but it's based on the individual risk assessment. So I think that this is where the internist, the GYN comes into play, that they make sure that patient gets a risk assessment to determine how do we move forward from here? Because there are recommendations to start things at 25 in some patients, recommendations to start things at 40 in some patients, but it all depends on what your risk assessment score is. So is there a role for mammal and alternating with ultrasound when you start your screening for the average risk person at 40? Alternating a mammal and ultrasound yearly is not a good idea because ultrasound is very operator dependent. So this tech does an ultrasound today and another tech does it 6 months from now. It's not the same test. It's dependent on, there's going to be human failure that goes in here. In the meantime, mammogram is done the same way every time because there's a protocol. It's also the only way to find the earliest form of breast cancer, which is calcifications, which is why we do mammography even in dense breast, because even MRI does not pick up calcification. So if we're screening to find early breast cancer, a mammo annually for an average risk has to be part of it, no matter how dense the breast is. In terms of ultrasound, if you're going to do ultrasound screening based on a risk analysis, it is done the same time with the mammogram because you're looking for structural abnormality based on breast density. Now, in terms of MRIs is needed as part of screening if your risk assessment score determines that you're at extremely high risk, over 20%, then we need to add another modality besides mammogram. And you're doing something every 6 months because you're trying to avoid what we call interval cancers. Having a normal mammogram in December and then developing a cancer in June, that's an interval cancer. If you're getting an MRI done every 6 months, you're going to find those interval cancers and take care of them while they're still early. But you have to meet certain criteria to get an MRI because it's not without problems. We think that there's going to eventually the buildup of gadolinium in the brain might become a problem for, all our degenerative mental diseases. So we don't want to do it indiscriminately for everyone because we still don't know the data on that.
Excellent.
Omar.
Dr. Garrison, go ahead.
Can I ask Jeanette to let's take a step back, and I looked at some of these questions, and I think they're all around mammography. Not all, but a lot of them. Could you talk about one? What are the indications to start screening for breast cancer? Could you talk about what a mammogram is? Could you talk about the safety in a mammogram, and then talk about mammogram versus ultrasound?
Can I just answer this for 1 second, guys? Give me 1 minute. I want to answer something on my phone.
No problem. No problem.
Okay.
All righty. I think this is a wonderful, wonderful webinar. And I'm just so proud and happy and elated that she's taken the time to educate us about this.
Okay.
Dr. Garrison, go ahead.
We need
Go
to
ahead.
know what's considered high risk also. Maybe she can introduce us to what she would consider.
Yeah, as far as high risk is concerned, definitely. We'll get to that. We have a lot of questions, and I want to try to get to some of those as well.
Nelson needs to be introduced.
Say that again?
Nelson needs to be introduced.
Oh, is he on?
Yeah,
Yes.
He's been sitting quietly for 10 minutes. I think he
know.
must
I
have
know
had
what's going on
laryngitis.
here.
Actually, okay. You know what happened is that on my screen, oh, there you are. My screen, the way my screen is, you weren't on my screen, so I didn't see you. I'm sorry, Nelson. Well, while we have a chance, why don't you introduce yourself?
It's always a pleasure to be here. Good afternoon, everybody. Sorry I came in late. Can you guys hear me?
Yes.
Yeah.
We can.
I think Dr. It froze. I'm not sure if it's on my end or from your end. Oh,
Yeah.
can you hear me? It
Yeah,
froze.
we can
Was
hear
it
you.
me?
We can hear you. Yep. Mhm.
Okay. Oh, okay. My internet was a little unstable. So yeah, I was saying it's a pleasure to be here always. Um, Sorry I came in late. I had to finish up with a few things quickly. So my name is Nelson Aluya. Medicine and pediatrics trained, been assistant professor, a chief medical officer. I'm presently consultant for St. James Healthcare Systems and the president and CEO of EraMed Medical Center here in in New Jersey, and I call myself a medical advocate. It's such a great pleasure to be here because breast cancer is, I think, outside of diabetes, is one of the other things that is affecting us, people of color, far more than we would hope for or hope not, and especially in countries that are transitioning as compared to transition countries, meaning countries that are developing and adopting. We use the word um, Western lifestyle, and we begin to see that across, Africa and most other developing countries. And unfortunately, our outcomes is worse than anybody else. And there's some genetic factors that are coming up, and we'll begin to learn as it goes on. And maybe the good Dr. McDonough will talk a little bit about that as well. When you talk about gene and the transportation of gene from way back home in Africa and to us here, and linking that also to prostate cancer and the increasing risk of prostate cancer for first degree family members who have breast cancer, and vice versa as well. So all of those things are things that we need to that begin to play into the literature and begin to wonder, is it just socioeconomics, or there are also genetic factors? And that's why we're different, so that we begin to pay attention, so that when great doctors like Dr. Omar Bey and Dr. Spratt and Garrison and everybody else who are at the forefront of healthcare services can truly advocate for their people and make sure that we save lives and livelihoods.
Excellent, excellent. All righty. Well, Dr. McDermott, thank you for coming back.
No, that's fine.
All righty. Let's get to another question. And Dr. Aluya, she did make some correlations between us being as a people from African descent and coming over here, but we're going to get into that a little bit more as well. This question, you discussed about.
Omar, I think I needed to answer the question about mammography and screening that Dr. Garrison asked.
Go right ahead.
Okay, so so mammogram is basically an X-ray of the breast, right? And we've had many different changes in how we do mammography over the years. And we're now doing mammograms, or, basically what we call digital tomosynthesis. So basically that allows us to see through the tissue based on technology of the breast a lot easier than we've done in terms of our analog mammograms in the past. So it's computerized, where it's like walking through a forest. You're taking small steps through the breast at the same time. So you're able to put the pictures together and then come up with the abnormalities. So it's, technology has gotten us a long way. Ultrasound is using sound waves through the breast and to find structural things. MRI looks at metabolic changes. So that's why MRI is a Cadillac of test relative to ultrasound, because when you do mammogram, looks at structural changes, MRI looks at metabolic changes. So they're a good complement for high-risk people. Okay. Now, screening traditionally is recommended for women over the age of 40, although it doesn't necessarily help us as African-American people, because we find younger breast cancer when we're not being screened, which is why it is, and our breasts are dense at 40. So at the end of the day, it's important to still be doing self-breast exams, which they say are not as useful, but you're going to know that there's a change in your breast before anybody else, because, you're not being screened before 40 in general if you haven't had a high risk assessment, which a lot of us aren't having. And so breast exam is important. We need to teach that, okay, starting at 25. And get your risk assessment at 25. At the same time, are there any increased risk for radiation from mammography? No, because the radiation that you're using for a mammography is less than walking to your car on a sunny day. So it does not increase your risk for any other cancers. But if you've had radiation for something like, say, Hodgkin's lymphoma or treating a thymoma or something like that, that does increase your risk for breast cancer if you're exposed to your radiation at the time when the breast is still developing. So usually if somebody's had radiation for any of these childhood lymphomas or cancers or anything like that, we start screening you about 8 years after your initial exposure to radiation, high dose radiation, because that's what the data shows when your risk for breast cancer increases in the medial portion of your breast. And you need to not just get mammograms, but you need to get MRIs. You're alternating mammograms and MRI because these are younger patients. And a mammogram by itself is going to find calcifications, early form of breast cancer, but will not find the solid lesions because your breasts are dense, and mammography has about a 40% false negative rate for dense breast, which is every woman that's menstruating.
Mhm, mhm. Now, when you said MRI is the metabolic, said metabolic entity, what do you mean by metabolic? You mean the activity of the cells, or you mean the how? I know when I think of metabolic, and we do PET scans from a pulmonary standpoint, we're talking about how actively the cells utilize oxygen and is utilizing the elements around it, stealing all the elements around it from normal cells. And that cell, that abnormal cell or that cancer cell, is growing at a faster rate and stealing everything from around it. How with an MRI, when you say metabolic, what do you mean by that?
So yeah, so it's similar in that the cancer has a signal, or anything that is active has a signal. So we know what the abnormal signals are for anything that has increased activity relative to the normal breast cell, right? So basically we've got a baseline, what we expect for a normal breast parenchyma, normal breast cell. And we've got what is considered a concerning MRI finding based on increased activity in terms of blood flow, oxygen, any of the factors that the cell is using. And you can pick that up because cancer has a certain signal, abnormal things like radial scars have a different signal. So that's why MRI is highly sensitive, with the specificity is not as great because it picks up things that are normal, but increase activity. But we need to verify what's normal, increase activity versus what's increased activity abnormal, cancer. So yes, it's a similar concept.
Excellent, excellent. Dr. Clark has just joined us. Can you introduce yourself? And then what I'm going to do is I want to get a question, and then we're going to our halftime break, and then we're doing a lot of questions because we have a lot of piling up. Dr. Clark, introduce yourself, please.
Sure, I apologize for being late. Dr. Kevin Clark, I'm a surgical oncologist. I work at Newark Beth Israel. Glad to be here today.
All right, excellent.
Welcome, Dr. McDermott.
Yeah.
All righty, all righty. The next question, you discussed about personalized care. Where do you think people can start after getting a mammography or a mammogram, I should say?
So part of personalized care is that risk assessment we talked about, right? So honestly, it is knowing your risk that determines how and when you should get your mammogram, because everything's not for everyone. So the risk assessment, there are risk assessment programs and different risk assessment available out there. There's some that are more geared toward the African American population, some that are not geared toward the African American population. So at the end of the day, of all the risk assessment models that are out there, the oldest one is actually the one that's been updated to include the African American population best, which is the Gale model. Because a lot of the other ones do not take into account, like second degree relatives, which impacts on us more than impacts on a lot of other people. And they don't take into account things like previous biopsies for benign disease that raises your risk. So we know that in the African American population, the more benign biopsies you've had at a youthful age, that increases your risk for breast cancer. It's not that way for any other population. So it's important to know which risk assessment tool you're using and make sure it's inclusive for the African American population, one. And two, to also get that risk assessment done to determine, do I need to start getting screening sooner, or should I stick to the age 40 screening, et cetera, et cetera. So that's, I think, is the most important thing. That risk assessment starting at 25 for everybody is probably the thing that's going to allow us to individualize treatment, screening, as well as treatment.
Let's get another question, and then we're going to go into our halftime break. What do you recommend for pain for a patient with metastatic breast cancer who has tried medications, the therapy she's tried, tramadol, that's really not working? She states, do you recommend interventional radiology? Interventional radiology, it says.
As
Or
well,
yeah, go ahead.
I mean, is she talking about, it depends. So I'd have to know a little bit more so to determine that, 'cause that's a very specific question. So in terms of interventional radiology, we're talking about nerve blocks, or we're talking about, I mean, some sort of pain management. I mean, there certainly is a role for pain management, depending on where your metastatic breast cancer is, if it's bone or, you know, that kind of stuff. So I would need to know more in order to be able to give a specific answer, but there is a role for them based on your, you know, where your stage 4 breast cancer is.
Okay, all right, thank you. Let's do this. Let's take a moment here, and what I first like to do is all the physicians to reintroduce themselves, because there may have been people coming in watching the webinar that after we did our initial introduction. Dr. Sprock, please, you're on mute.
Kendall Sprott, retired pediatrician in both critical care pediatrics and general pediatrics.
All righty, excellent. And Dr. Garrison, please.
Jordan Garrison, board certified general and vascular surgeon, specializing in venous disease, located in Hackensack, New Jersey.
Thank you. Dr. Jeanette McDermott, please.
Janet McDermott.
Janet, I'm sorry. I told you I was
That's
going to do
okay.
that.
Everyone
Jeanette,
does
I told
it.
you I was going to do it. Go ahead.
Breast cancer surgeon, RWJ Barnabas Health, and basically working on multiple facilities at this point, and board certified. Pretty much happy to be here.
All righty, thank you, and we're happy to have you. Believe me, Dr. Court, please.
My name is James Court, internal medicine. I only treat adults. The office is located in East Orange, New Jersey.
All righty, Dr. Aluya.
Yeah, Nelson Aluya, medicine pediatrics, a medical advocate. Always great to be here, listening and learning from great minds as well. Thank you.
All righty, and Dr. Clark, one more time.
Dr. Kevin Clark, surgical oncologist. Glad to be here.
All righty, and I always forget to introduce myself. I'm Dr. Omar Bey, and pulmonary critical care and subspecialty in nutrition, and I am overwhelmed with all of the excitement about this breast cancer talk, and just so happy that Dr. McDermott has come and graced us with all her knowledge. Let's do this. I want to get to some more questions. All right, we talked about the pain. All right, there's another one about mammograms, and I just want to read this one because there's so many. I have heard that mammograms are risky in itself because the exposure to X-ray, and I think you answered this question, but it's one that's coming up so much. Can you answer it again? Are there other ways of screening, especially for women with large breasts? And that was a question I was going to ask, as far as large breasts. And not only with the screening, but as far as outcome with surgery and prognosis, as far as, you know, whether they have a worse prognosis in the end.
Okay, so
Is
as
that all
I
one question?
Yeah, I added on a little bit to that one. Sorry about that, Doc.
that's all right. The safety of mammograms are extremely safe. And like I said, that there's a lot, particularly these days on TikTok, people keep sending me these things all the time about thermograms and all these other things that we visited before, and they're coming back. But I mean, there is still nothing out there that is better than a mammogram, right? So there are different types of mammogram now. There are now newer mammograms called contrast enhanced mammogram, which is a technology that's been out for at least 7 years or so, well documented, to show that it's actually more sensitive than regular mammography and definitely more specific than an MRI, but it's not available in all communities. So some places that everyone gets a contrast enhanced mammogram, and they're not getting, so you're getting like you'd be doing a CAT scan, you inject a contrast, you do the mammogram. It is sensitive and more specific than an MRI, but it's not available out there. Okay, so basically that would be somebody, and the radiation exposure to that is not in any way proven to be dangerous for the benefit. So mammograms are safe, and I still think it's the gold standard, and that's what we should be doing for the most part. When it comes to large breast, I think like anything else, when you get, whether you've got large breast or small breast, the most important thing is where you're getting your screening done, right? Because what I say to people all the time is that a general radiologic center doesn't always have people that are breast specific or mammographers. And if you're getting something done in a center and they're outsourcing this, you get a mammogram done here and it's outsourced and it's read in India next week or whatever it is, who's reading it? And it's very important to have people that are good, trained as mammographers, because it makes a difference. So you just can't go anywhere. So if you've got, specific issues, dense breast, large breast, you need people that have techniques that are going to be able to make your screening worthwhile, because it's not just enough to get screened, it's enough to get good screening. And so there is no, you should not have a breast center or a center with trained mammographers having a problem doing mammography on somebody because of a technical issue like large breast, small breast, dense breast, because that should be in their purview. That's their area of expertise. So more importantly than just getting the screening is making sure you're going to an accredited center, a center where you have the people that you need to do the work that you need.
Dr. McDermott,
Yes?
the difference between a screening and a diagnostic mammogram.
So a diagnostic mammogram is done whenever there is some abnormality, something that's not seen on the opposite breast or on previous mammograms, seen on your current mammograms, because usually they're comparison views, right? So you're comparing the right and the left breast, or you're comparing previous films from previous years. So if there's something found on a current screening film, then you need to do a diagnostic film to see if this thing that you see is just breast tissue, or is it a real finding that we need to address? And so a diagnostic mammogram essentially interrogates a finding seen on the screening mammogram. And sometimes you need to put an ultrasound as part of that.
Is there a different technique being used for a diagnostic?
Yeah, it's basically a diagnostic. So when you do a screening mammogram, you're doing two standard views. And that's not being done with any radiologist looking at it at the time of the study. It's being done by the tech. The tech says technically this looks fine, but they're not interpreting it. So the screening is done, and then a radiologist looks at the screening and says, hey, there's something here. We need to bring this person back. And then the radiologist is actually there at the time of the diagnostic film being done. They're directing the way the film is being done. So you're doing special compressions. Sometimes the radiologist is actually the one that's doing the ultrasound, not the tech. So yes, by it having the presence of a trained mammographer is part of doing a diagnostic workup. Being there to direct the way it's done, as well as sometimes physically doing the test, is part of it, as well as the way it's technically done is part of doing a diagnostic workup.
Thank you.
Dr. Sprout, you're next, please.
Yeah, you just briefly mentioned ultrasound, and that was sort of my question about the use of ultrasound in women with large breasts or dense breasts, and its use in possibly directing where to biopsy if indeed there's something that's suspicious.
Okay, so ultrasound for dense breast, large breast is certainly one of the modalities we use for screening, right? And that depends on what your risk score is. So that whole risk assessment I keep going back to. So let's talk about what that means. What we do is we look at how many biopsies you've had, family history, if you've had any, gene testing or anything like that. And we look at your breast density, and we come up with, a risk score based on whatever model we're using, and there are a couple of different risk scores, okay? And if the score is greater than 20, it means that you should be getting mammogram once a year and MRI once a year as part of your screening, because Anything else is going to be suboptimal. Okay. Now, when you do that kind of screening, you're not doing the mammogram and the MRI at the same time. You're doing the mammogram, say in December, you do an MRI in June. So you're spacing them out 6 months apart. If your risk score is under 20 and you have dense breasts, then basically you get a mammogram and an ultrasound as part of your screening done at the same time every year. And so basically that's to basically look at any abnormality that requires an ultrasound guided biopsy or further workup by maybe an MRI, because you can have an abnormality on ultrasound and it's not really clear what it is. So now you need to add an MRI as part of the diagnostic workup. So yes, ultrasound is useful and it has its place, but it's not always the best test based on what you're trying to accomplish.
How amenable are insurance companies to authorizing MRIs?
Well, we're fortunate to some respect because we live in New Jersey. So New Jersey is one of the first states to adopt that whole dense breast posture. And that came out of a lawsuit of a woman that had a mammogram done. And then 2 months later, she noticed a lump and she had a normal mammogram. So then, she had a breast cancer, and it took years of advocacy around that. And New Jersey actually made that dense breast law at least 7 or 8 years ago. The federal government actually adopted that and a couple of years back, but they just started mandating it September of this year. So because New Jersey is one of the few states that had the dense breast law, insurance companies basically in New Jersey has always paid for ultrasounds and MRI if you meet those criteria. So that's not a problem, but that's one of the reasons sometimes people come to me, because even though they don't have a problem, is to get them to where they can get that MRI done, because you have to know what the criteria are and you have to know the language and you have to know all that stuff to get it paid for. But it is mandated to be paid for by insurance company as long as they meet that criteria.
Do you think most internists and OBGYN doctors or gynecologists know about this?
I would think so. I mean,
You would hope so.
yes.
Let's be real now. You would hope so.
Right. All right. Dr. Aluya, did you have your hand up?
Yes, I do. To the point of the MRI and the ultrasound, in all sincerity, I haven't had any issue or concerns with that. Usually when I refer patients to go do that, they usually do it and they don't come back bouncing back with prior authorization. That's the good thing. Thank God for that.
Yes.
My question is this: the incidence of breast cancer in the U.S. The average is about 62 or 63 years old. But what I've found out as we go on, and I've seen, because I ran a cancer primary care cancer site at Rutgers University a few years ago, and I was beginning to see a lot of young women with breast cancer, predominantly Spanish, but then this was a little alarming and very concerning. What's your take on that? And why is it that their outcome is far more worse than the average? Because if you look at the data, they're likely to a 40% chance of dying compared to those who are that age.
Well, first of all, the breast cancer that we see in younger women tend to be more aggressive, right? And on top of that, they're usually not at screening age yet. So they're caught usually in our population at a later rate. And a lot of times when our population goes to a physician and say, I feel something, and they ordered, say, a mammogram, and the mammogram shows nothing, which is what I would expect, okay, because they have dense breast, then nobody goes on to pursue that. Because my youngest breast cancer patient is 19, and it took her 6 months to come to me because even though she said I felt something, her doctor didn't think they felt something. But then when they sent her for the mammogram, the place said, oh, everything's fine. And by the time she came to me, she had like something the size of a grapefruit in her breast, which they could no longer deny. So there are a couple of different factors here. You have to be persistent, one, and this is it. I'm not going to stop here. Okay. Second of all, the fact that the breast cancer is more aggressive at that youthful age is why our outcomes are so bad. And then there's also the issue of, do we get access to everything? Because it's been shown that some physicians are uncomfortable offering clinical trials to African Americans or whatever. So there is some doctor biases there that's been shown. And then there's also the issue of us being, basically not trusting the system because of what's happened to us historically. So I see people that clearly have curable aggressive disease and they'll say, I don't want chemo. I don't want whatever, because I either don't want my hair to fall out or I don't whatever it is. And at the end of the day, you can't talk them into it. So some of that is by choice. And some of that's the fact that they think that we're experimenting on them, although I've tried to tell them that, the days of the Tuskegees where we had so much representation in medicine. And I, as a physician, am here telling you this, and we're going to monitor this. It's like nobody gets sent to a trial without the person sending them to a trial still intimately involved. So, I mean, there's so many reasons, but yes, I think part of it is that, the quality of care is different. Not only that, sometimes we don't have the insurance that allows us to get the same treatment because, the Affordable Care Act has opened up a lot to us, but what is a lot? Can we get the genetic testing covered? Can we get the MRI covered? Can we get whatever? Because those are the times I meet the limitations. Because, okay, they have Medicaid or they have, some sort of subpar insurance and we can't get everything. And so the outcomes may be worse because they're not going to pay for these, immune therapy or whatever it is. Or the patient doesn't want to go on trial, where on the trial you get those drugs for free. So there's lots of issues.
Well, I guess it's time for us to eventually have some form of a breast cancer or a cancer insurance, just like we do with the Ryan White for HIV. There has to be some advocacy on this going on, so that once you get diagnosed with breast cancer or any other kind of cancer, then you have access to care. Because I'll tell you this, I just did the floors and I had a patient who had breast cancer, had insurance, was working, and then lost the job, and then was no longer covered. But because she was no longer covered, guess what? She couldn't get care. And for so long, she just was frustrated, the whole process, and then never showed up until one day, pain, ER, got admitted. And then, you understand? So, and then she needed to have radiotherapy, but she can't get radiotherapy and the other kind of treatment at home because she has no insurance. So they have to keep her in the hospital, get all those sessions of radiotherapy in the hospital. So you can imagine how much cost that is on the healthcare system. So I don't know.
Well, I say the healthcare system is penny wise, pound foolish,
Yes.
because honestly, that goes into the whole, prevention. They don't pay for prevention, right? That goes into the whole thing of getting early, doing all the diagnostic tests to find early detection so you need less. That goes into the whole system of having some sort of, backup, some cushion for people that don't have insurance, which, or lose their insurance. Because I have been where you are with that patient, where they start out, they have insurance, and I have to change my whole approach. Sometimes I end up doing surgeries that I wouldn't have normally done on a patient upfront that needed chemo upfront, because I know they're going to lose their insurance. And so I need to get this done, because otherwise I'm going to be left with them not being able to get that. And then it takes them 6 months to get charity care. By then it's, it's already advanced. It is very frustrating.
Yeah. It's the medical system and the jockeying that we have to do is tremendous sometimes to take care of our patients. Dr. Patrick Anderson just came in. Patrick, please, can you introduce yourself?
To the crew, I apologize. I kind of got stuff done at the hospital. I'm Patrick Anderson. I'm a gynecologic oncologist. I've been privileged for many, many moons working with these illustrious physicians. Dr. McDermott, my neighbor, Dr. Garrison, my friend, Dr. Sprott, my professor, Dr. Clark, my day-to-day, Dr. Aluya, I don't even know what you are to me, and Dr. Court is my dad. So happy to be here.
Going down that line.
I love it. Now, Dr. Garrison, you have your hand up.
Yeah, one comment to Dr. Aluya and then a question to Dr. McDermott. One comment, having worked in the breast centers at both St. Michael's and University Hospital, no patient who ever came in was ever turned away because of lack of insurance. So though there are treatments and there are availability, albeit not as advertised, but one of the things that what prevents patients from coming in is fear. The fear that they won't be able to get treatment. So they just don't do anything. No. And that's what my question is to Dr. McDermott. A lot of the times patients have fear about going to a breast surgeon, and a lot of it is they think I'll get diagnosed and they're going to take my breast off or I'm going to die. Could you kind of walk us through an algorithm of a patient who might come in with a breast problem and somebody that is negative, what you do, somebody who's positive, what you might do, so we can help alleviate some of that fear that might be out there?
So yeah, my first thing, and I realize this, a lot of times patient comes in with a breast problem. And I realize that they're not going to ask me what they really want to know, which is, am I going to die from this? So I try to basically get as much information as possible about their specific problem to be able to tell them realistically what my expectations are, right? So, it's an early breast cancer, the characteristics in terms of the, what type it is favorable, if you can have a favorable cancer. So I try and make sure that I drill through all the things with them to make them understand that this is going to have a positive outcome. Okay. And even if you wanted to get some time to get a second opinion, you have enough time to get another opinion. It's not going to impact on how well you do. Because I think that the biggest thing is that we've made this so that I think it's between, the media and friends and family and, social media, where breast cancer, which is the most favorable cancer, has gotten this negative rap. And of course it sells, eyeballs for the media. So there's a lot of, that out there, which is not necessarily because you don't hear the good stories. And at the end of the day, we have come such a long way in being able to treat even the most aggressive breast cancer. I mean, most of us are going to do well for the most part, that I try to make sure I go through all the possible scenarios with the patient, let them know they're going to do well, no matter what, because we've got some options here. And I mean, so that would be a patient, negative or positive starting out. I try to anticipate what they're really thinking. And most people don't ask, is this genetic? Am I going to die from this? Where am I going to be from here 5 years from now, 2 years from now? What are my life goals? I try to go through that with them. It's what is it that you plan for 5 years that you're trying to make sure you get to? Because it's important to be able to walk that patient through that for them to realize that this is a collaborative thing and we can make it through this, understanding that you're going to survive this, which is most of them for the most part.
Let me do this. I know several have hands up. Hold your questions. I want to get to some of these questions that the audience have put forth. I had a biopsy last Friday and the report identified 2 precancerous cells, which are contained within the ducts and not invasive. What do you recommend as the next step for treatment? I will meet with the breast cancer physician on Thursday.
Okay, so that term precancerous cell is very generic, right? So it could be that she's got a stage 0 breast cancer. Some people call it precancerous. It could be a high-risk lesion that doesn't need any surgery, but it needs what we call chemoprevention, where you get your risk analysis and determine if you benefit from taking a pill to, protect both breasts from breast cancer in the future. And then there's also the precancerous cell that requires further surgical intervention to actually drill down into what kind of precancerous cells you have. So her information is relatively general, but there are like 3 possibilities. I mean, but it doesn't sound like any of that's going to be something that's going to impact her long-term negatively. So I'm sure that her meeting with the breast surgeon will not be something that she'll walk away feeling that this is a death sentence, whatever it is. But it all depends on what the precancerous cell, you have to be more specific than that for me to be able to make any suggestion. Plus, I'd also need to know family history and all the other stuff that comes into play to make some suggestion. So it's not, like I said, it's an individual thing. And all the information she'll provide for the breast surgeon that she meets with will help determine what happens from here.
Okay. One more question, Viva, and then we'll get to some of the hands. Is there a correlation between having large breasts and cancer?
No.
Gotcha.
So basically, large breasts, it might be harder to examine your breast, do self-breast exams. And it might be, if you're not going to a center that's going to make sure they do a mammography in a more, detailed fashion, they might miss something. But in general, there's no correlation between large breasts and breast cancer.
All right, and you answered that so well. Does physical abuse to the body cause breast cancer?
Well, when you say physical abuse, so I think of physical abuse as in different levels, right? So I think if physical abuse stresses your body, it's going to contribute to breast cancer. So it could be physical abuse that, basically you've got some body dysmorphia, so you're not eating well and you're exercising excessively, and so your body's not getting a chance to recuperate or that's a stressor. So anything that's a stressor in your body is going to increase inflammation, and it is going to increase your risk for breast cancer in general.
All righty. Dr. Aluya, we're moving along.
Yeah.
All righty, because we got a lot more questions to answer, and I want to get the hands done too. Go ahead, Dr. Aluya.
All right. So globally, about 12.3 million people diagnosed with breast cancer, 670,000 dying from it. In the US, 300,000 dying, diagnosed, and 42,000 dying. And then we tend to forget about men too, breast cancer in men. I don't know how many you've seen in your practice and if that is coming up. But my question is this: with all that data and everything else coming, I'm a futurist, and I like technology with everything, mixing the whole thing up. What is the future of diagnosing, treating, and managing breast cancer in the space of AI and mRNA technology and CRISPR and all of this coming up? What are we to look out for, and what are we to teach those coming behind, and teach our patients as well to say, listen, this is what's coming. Pay attention. Be ready to advocate for it, and also have access to it.
So let's talk about CRISPR, right? So CRISPR is a great technology. It's going to allow us to change up the way we engineer our genes to be able to, protect against known genetic mutations, right? So it's going to be helpful for those of us that have a gene or something we can identify that we can change, right? So CRISPR, I think, is definitely something that is on the forefront. It's going to be helpful for what we know right now genetically. We're always updating that. So, there's always new things, cutting edge things in terms of new genes, whatever. But then we also have to determine when we find these things, how significant they are. And that takes a while, right? Because we know at least there are 9 actionable breast cancer genes right now. Not all of them need some sort of prophylactic mastectomy or whatever it is, because as we get older, we outgrow some of those risks. So when you find these things in somebody, you have to look at how old they are when you find them. Where do you go from there? So again, individualizing it. So that's the future of breast cancer, right? As it comes to CRISPR. When it comes to AI is going to be really good in terms of us being able to detect earlier breast cancers. And I think AI is going to also help us from a surgical standpoint to be able to to do surgery that is less deforming. So you're going to be able to use AI technology to help with how you use, say, MRI to help design your surgical intervention. And there's some of that going on right now, all experimental, but certainly, AI is going to be significant in terms of surgical, in terms of diagnosis. It's going to be important in terms of determining how you surgically manage things, being able to do less deforming surgical treatment, which we've come a long way with that as is now. And that I think is the future. And that's pretty much what I could speak to at this point.
All righty. Excellent. Dr. Court, you're next, please.
Just for information purposes, for the doctor to explain the indications for BRCA gene testing and the relationship between breast and uterine?
Okay, so BRCA1 and BRCA2 are probably the earliest and the most widely publicized breast cancer gene. And that was back in 2005 when Angelina Jolie sort of put it on the, public forefront. Since then, we've identified other genes that are probably not as significant, but, one or two that's equally as significant. So we know that BRCA1 and 2 were initially found in the Ashkenazi Jewish population, and it's not seen as commonly in our population. Although when you have the more aggressive type of breast cancer, the triple negative, there's a 10% chance that you could have the BRCA, one of the BRCA mutations. BRCA2 is more common in men than BRCA1, although breast cancer is only 1% in men. And in terms of the significance is that if you are a BRCA1 or 2 carrier, it also tells me about your risk for things like pancreatic cancer and ovarian cancer. So that's going to be important in terms of screening, okay, and where we go from there. But fortunately, one of the big things about doing the BRCA1 or 2 in any breast cancer, because now insurance pays for gene testing in everyone that has breast cancer, no matter what age, because it impacts on family. And the reason that becomes so important is that now we're able to actually do, not perpetuate this disease. I can send a BRCA1 or 2 patient before they have kids or whatever it is, if they're not a cancer person, to get to IVF, and they can do egg retrieval. They can determine which eggs have the gene, and then reimplant the non-impacted eggs so that you don't have to perpetuate this disease. So we've come a long way. So it's not only just for breast cancer treatment, ovarian cancer, pancreatic cancer, but it also helps us to stop this disease in the family. So that's impactful for BRCA1 and 2. Also things like PALB1, which is another high penetrance gene. But I mean, genetic breast cancer is only 15% of what we see. Most of the other breast cancer is based on all the other things that we do to impact our health.
Dr. Garrison, you're next, please.
Okay, just about a small story about breast cancer in men, that there was a famous actor, everybody will know him as Richard Roundtree, who played Shaft. And he almost did not get the role because they take out insurance on you. And the doctor who did the exam on him never asked him to take his shirt off. And if they had, they would have seen that he had had a mastectomy for breast cancer. And he became an advocate for breast cancer in men. Small story. But I'm glad that you brought up, my question was going to be about the breast cancer genes, and one particular, how do you approach it when somebody has a breast cancer gene? And there's been this advocacy at one point in time that women were having bilateral mastectomies. And, my thought was always that if they did develop a cancer, the treatment would be less invasive than the prevention. So what are your thoughts on this kind of movement towards these prophylactic procedures?
I think there's less of a movement towards it because we know that we can do the screening. And if you develop breast cancer based on having the gene, it's going to be treatable, and you'll still need, highly unlikely that you're going to need chemotherapy because you're going to find it early. So that's the whole idea now with better screening. So I think that women are less likely to go to prophylactic surgery these days. Not only that, we know that if you have one of those genes and you're 40, then your treatment is going to be different than if you're 65, because at 65, your risk for developing breast cancer with a BRCA mutation is almost the same as the general population, because you do outgrow your risk. So it depends on when you find it, what we determine what's the best way of treating the patient. So if you're just screening and you have a BRCA, no cancer, you certainly have the option to go do mammograms and MRI screening. And if we find something, it'll be early. It will not impact on your life. If you have a breast cancer and you're young, under, say, 40 or so, then we will normally recommend bilateral mastectomies, one for treatment, the other one prophylactic. But if you're, basically even 65 and you've got a breast cancer and you're BRCA positive, we don't recommend bilateral mastectomies.
Why would you do the prophylactic mastectomy on the contralateral breast in a young woman?
Because the chance of breast cancer developing in that breast is over 50% over her lifetime in a younger woman versus somebody who was going to have 18% at 65.
Mm-hmm.
So to add a little bit on the BRCA thing, in all sincerity, I grew up, I was born in Nigeria, I grew up in Nigeria, I studied in Nigeria, and especially in the northern part of Nigeria. And one of the very disturbing things when I did surgical rotations, and we had to do, community outreach, right into the villages, and some of them in the teaching hospital, was when I saw very young women, some of them still with babies, with fungating breasts coming into the hospital. I've always wondered, like, what the heck is going on? Why are we seeing younger and younger women and who had breast cancer and fungating? Because by the time they come in, it's way too late, and the diagnosis wasn't done. And at this time around, we never knew anything about the BRCA1, BRCA2. But new researches have shown that younger women, especially in northern Nigeria, that I used to see back in the day, now I'm beginning to tie up the strings. Young women, especially in northern Nigeria, have a much higher incidence, 15 to 22% of BRCA gene with an aggressive breast cancer in them. And that has been traced all the way down to incidence of prostate cancer, and unfortunately, prostate cancer in the Caribbean, and not with men.
Answer my phone. 1 second. I'm going to be right back. I told them I was going to be busy, but they're not.
Okay. All righty. She's no, but you can go ahead, Dr. Aluya, and
so
express yourself.
Again, we're becoming a global village, and people travel, and we're going to see all of these things. And if you had talking about genetics and everything else, maybe that's why we have more aggressive breast cancer in African American women now as compared to anybody else. And especially when they talk about what's it called? The expression of a protein. I think it's called the HER/new protein, which are proteins that are normal for normal growth of cells. But then in breast cancer, they're especially expressed. And that's been shown to result in very aggressive breast cancer. Again, looking at all of these things, when I look about population health and global health, I think there's more research that we can do looking at Africa that can help settle or solve problems of people living in the Western world, because you have to go back to the roots and see where things are coming from.
Right, Doctor. Thank you, Dr. Anderson. Dr. McDermott will be back in a minute, I'm sure. I understand she's in the middle of a lot going on as far as from the hospital as well. So she's just answering her phone. So she'll be back in a minute. But Dr. Anderson, as far as the BRCA gene and other genes and what you do as far as GYN is concerned, is there a relation with that? And do you find that? Do you look for that when you're treating someone from a GYN perspective when you're talking about cancer?
I think, the Cancer Genome Atlas has really helped us quite a bit in terms of risk assessment and identifying folks at risk and folks who can implement some degree of prevention. We touched briefly on prophylactic mastectomy, but we also, on the GYN side of things, patients who have diagnosed breast cancer, who have the BRCA gene, they themselves are at risk for ovarian, and some uterine cancer. And in terms of timing, one can talk to those patients about prophylactic surgery. The real difference here is having an intervention that has a visible impact, that has some sort of somatic stigma, as it's different in my world. It's different in Kevin's world when we do colectomies to prevent certain types of cancers versus breast. a breast program is never complete on just having the breast surgeon, right? We need to have reconstruction, um, and we need to have psychiatry, and we need to have physical therapy, because not all of our intervention result in the effect that we're looking for, and oftentimes we need these interventions to marry skin to manage skin changes, to manage lymphedema, and those kind of an issue. In my world, and to some extent in Kevin's world, no one sees visually the outcome of what we do. The result of what we do, we really see it 50 years, 20 years down the road from the intervention. Did this patient develop an ovarian or uterine cancer or an ovarian-like cancer? And what I mean by that is, there is not just the ovary that's influenced by these genetic abnormalities, but the lining of the abdomen, which has a similar histologic structure as the covering of the ovary. Some patients can develop those kind of cancers too.
Excellent, excellent. You had a question also, Dr. Anderson. Your hand was up.
Yes, I wanted to ask Dr. McDermott, from using genetics, is there a role for chemo prevention in patients who have certain genetic abnormalities, or whether they even fall in a risk category? And the reason I ask that question is, in the tamoxifen world, and that data may be old right now, you see benefits in the opposite breast from being on tamoxifen, which helps to treat the active disease. So is there a role to use those kind of medications to prevent the cancer in patients who are known risk for breast cancer?
Yeah, actually, tamoxifen has been proven to be one of the risk reduction options for people that are BRCA positive. Unfortunately, the problem with that is that most of the time these people are still not done with their childbearing age. So basically, if you're still planning on having kids, tamoxifen is something that you don't want to put somebody on until after they've completed, what they've decided that they want to do from the standpoint of having kids. So I find that most of the times when people refuse tamoxifen, it's based on the fact they're planning a pregnancy, and so they don't want to do it, or my medical oncologist will wait until after they've completed their childbearing, and then they'll put them on tamoxifen after for chemo prevention, because that is proven to be effective, yes, in the BRCA carriers.
Okay. I just have to ask one thing. You had said something about triple negative. Now, can you go through, I know that we talked about the BRCA, but what other elements do you look at to determine what stage of breast cancer is, that stage is? Triple negative, what does that mean?
Okay, so triple negative is the most aggressive type of breast cancer. And it is also the type of breast cancer that is more prevalent in African Americans than it is in Caucasians. So the percentage of triple negative breast cancer you see in Caucasians is about 12%. And in African Americans or anyone from the African diaspora, based on the transatlantic slave trade, it's about 25%. And what does triple negative mean? So when we get diagnosed with a breast cancer, we look at what we call markers. And these are things on the surface of the breast cancer cells that helps us determine how aggressive that cancer is. So basically, most garden variety that in the invasive ductal breast cancer tend to respond to hormones, estrogen and progesterone, which are hormones that every woman's body makes. It's more prevalent in the ovaries when you're premenopausal. It's made in by muscle, subcutaneous fat, and other parts of your body when you're postmenopausal. So, and there's another marker that's called HER2/neu that's also on the surface of the cell that we look at. So these three markers are the things that determine how aggressive a breast cancer is and helps determine treatment, and in some cases helps determine what kind of immunotherapy is going to be effective for the treatment of the patient. So basically, if your breast cancer does not respond to estrogen on the surface, which is information you get from the biopsy, does not respond to progesterone, and does not exhibit HER2/neu, it's considered a triple negative breast cancer. And it is one of the more fast active, more aggressive breast cancer that's out there. But like I said, we've made gains in terms of how we treat it. If someone has a triple negative breast cancer and they have a BRCA mutation, then they are a candidate to get specific immunotherapy that is targeted against that type of triple negative breast cancer. So your treatment changes versus if you're not BRCA positive. And also there are other treatments out there for people that don't have the BRCA mutation that are triple negative, that are also immunotherapy. So each cancer is treated with different types of immunotherapy based on characteristics. And that's something that has actually been a game changer in terms of how well you do. So that's one of the things that we talk about, precision medicine, individualizing treatment. That's been at the forefront of how we've been able to make things like triple negative breast cancer, HER2 positive breast cancer, which is that other marker on the cell, chronic disease with good quality of life.
Excellent. Dr. Sprott, your hand's been up and you've been patient, and thank you very much.
No problem. Two things. One, the issue of artificial intelligence. And, years ago, I went to a conference where they basically said artificial intelligence is going to take away a lot of the things that both the radiologists do as well as the pathologists. And so these artificial intelligence is able to better pick up abnormalities on mammograms and x-rays and MRIs and CT scans. And the same thing when you do a biopsy. You take the biopsy, you put it on a slide and you examine it. And they said that AI is better at picking up abnormalities and pathological slides than that. So that may help to a certain extent. But the one thing that has been talked about is, I'll say the use of, or the role of hormones in the treatment of breast cancer. And this is expanding to Patrick and to you, as well as Janet. And that is, we often look at those areas of the world or countries that have the highest incidence of certain kinds of cancers or cancers in general. But the opposite end of that is that there are countries and areas of the world where cancer is a lot lower. And someone talked about the westernized diet. But there are certain areas that have low incidence of cancer, and a lot of times they talk about the diet that's associated with it, as specifically for breast cancer. And this is a kind of a tricky name, but cruciferous vegetables play a role, an important role, they think, in decreasing the incidence of certain kinds of cancers, including maybe breast cancer. And could you tell us a little bit about the role of cruciferous vegetables and their relationship to estrogen and maybe the possible prevention of certain kinds of cancers? Patrick, I know you're big on
What are examples of
vegetables.
cruciferous vegetables?
Those are like broccoli, cauliflower, cabbages, those kind of vegetables.
Kale,
Yeah.
Brussels sprouts, arugula.
Yes.
So, those vegetables, let's put it this way, are, there is, when you talk about cruciferous vegetables, right? When you look at the studies that are out there, there is not a whole bunch of studies in the general literature, right? But when you look at the literature from the holistic standpoint, the integrative medicine standpoint, there is more data out there, right? And so there's always the question of whether or not that data is data that is translatable because it's not been recognized by the people that are really not into prevention, which is they're motivated to make money, right? Because people are not in prevention because prevention doesn't make money. And that's what a lot of this is all about, if we're honest about it, right? Yeah. So at the end of the day, the data from the integrative medicine is compelling that yes, that does decrease your risk for breast cancer, cancers in general, and any disease that's related to inflammatory processes, because the whole concept is how do they impact on the inflammation in your body? That's
Well,
really
part of it was not just inflammation, but what they talk about is the phytoestrogen
Estrogen.
that's
right.
present in these types of
Yeah, but
vegetables.
phytoestrogen is another story altogether, right? Because
Right.
let's put it this way. I'm vegan, right? I eat a lot of tofu, tempeh, all that kind of stuff, edamame. At the end of the day, there's a lot of data out there that says that, you know, you shouldn't be doing that as a breast cancer person. And when my patients ask me, can I do this stuff and I have breast cancer and my cancer is hormone responsive, I say to them, absolutely you can. You know why? Because if those phytoestrogens were a real problem, everyone in Japan and China, breast cancer would be an epidemic in those areas. And that's not what we see. And the problem is all the studies that looked at phytoestrogen showed that there is no increased risk for breast cancer related to phytoestrogens. If you're eating, I'm not telling you to go out and get supplements, but you're eating your stuff, your body's going to get rid of what it needs and takes whatever, just like we talk about breastfeeding and how it impacts on your breast cancer. The problem, it does have some benefit, except that we don't breastfeed long enough in this country for it to impact because we're going back to work or whatever it is, and you don't get paid to be off long enough. You need to do it for at least 2 years, one. And three, we're not eating enough phytoestrogens for it to protect us against breast cancer in this country. But if we were, has been found to be, on the limited studies that have been done well here, to be protective, not in any way dangerous. And so I tell all my patients, there's no reason for you, because you've got a hormone positive breast cancer, to give up eating those things that are considered phytoestrogens. And I certainly, that's my major source of protein. And I have no concern that one day that's going to be what I have.
Mm-hmm.
So that's an interesting conundrum, right? Because if we know the Women's Health Initiative study that looks at probably 20,000 postmenopausal nurses, you see a subtle incidence, and I may be off, but not by a lot. I think it was 8 in 100,000 women who developed breast cancer on that study. That study was interesting in that patients were not categorized based on a risk assessment. Right. It was just a prospective randomized trial based on who's menopausal, right? So I think if you had identified patients who have intrinsic risk factors, then the ones who did not have those risk factors would benefit from the hormones. But what came out of this is what the patients who received estrogen were the ones who were at risk for developing the breast cancer, right? And not the progestin, right? And maybe we should define estrogen and progesterone, which are two hormones, which from my circles are produced primarily by the ovaries. And in theory, the progestin counteract in a cyclic manner the effect of estrogen. Now, how does native estrogen differ from phytoestrogens that makes it safe, or make me want to say to a patient who worry about the risk of developing breast cancer on hormone replacement therapy, that it's okay to use these plants like soy and so on that are rich in phytoestrogen?
Yeah, that is a conundrum, because the point of the matter is this, is that nobody is going to do that study well in this litigious society, but I think the study is being done naturally by all the people that are, so yes, risk assessment is going to be important, and that wasn't done, one. Two, what currently, right, what we're doing is that the studies have shown that if you have, say you're a BRCA positive patient, we talk about, the use of estrogen as prevention, or what's the risk for somebody who is no longer without a uterus or whatever it is, or because they've had, preventative surgery because of their BRCA positivity. We have no problem having that patient use estrogen for all the positive effects, because none of the studies have shown there's an increased risk for breast cancer for someone who hasn't had prophylactic mastectomy, no longer have ovaries or uterus. Okay, so they're getting screened with mammograms and MRI for their breast. We have no issues. The studies have shown that for them to take estrogen for their vasovagal symptoms or all the other symptoms that comes with lack of estrogen, or to help them with bone density, increases their risk for breast cancer. And those patients are BRCA positive.
And also what we do know that in both the breast cancer literature and the estrogen-driven literature,
Mm-hmm,
endometrial cancer literature,
mm-hmm.
that patients with early stage breast and endometrial cancer, there is no real increased risk of recurrence of their disease on hormone replacement therapy.
That is true.
Yeah. Hmm. All righty. Now, let's do
I
this.
have a question
Doctor,
before we.
hold on, Dr. Aluya.
Yeah.
Dr. Court, you had your hand up. Is your question answered? You're still on mute, Dr. Court. Can you take yourself off mute?
I think he's has his hand down.
Still
He's still
on.
on mute.
On mute. It's okay now.
Mhm.
Uh-huh.
My question was since stress and the use of these types of foods that play a role in development of cancers, that should be a take-home lesson to
Mhm,
all of us listening to this webinar today.
mhm.
In those countries where there's a high incidence of breast cancers, right, in particular, do you know if these people are always subject to a high level of stress? Say, like people in the third world countries, they are less stressed or more stressed than people in first world countries.
Mhm. True, true.
Oh, as a third
I
world
mean,
person myself.
yeah, yeah,
Developing countries then instead of third world.
That's fine.
Mm.
As a person from developing countries or whatever it is, the point it matters that there's always stress, but stress is all relative. I think that
right.
stress in those countries is a very different stress than living in America. I mean, so I mean, I do missions all the time in the Philippines. And what I found is that the instance of breast cancer in the Philippines is the highest in all of Asia because pretty much they've been impacted by the American influence, right? They eat the same way Americans do, they're less active, they smoke a lot, whatever, as opposed to the other Asian countries that have sort of stuck more to what's their traditional way of life. So at the end of the day, I think that, it's all stress and diet and lifestyle things is all relative depending on where you are. So I don't think necessarily in developing countries, stress is playing that major a role in terms of breast cancer development because breast cancer incidence is not that high for people that are sticking to traditional ways of living, right? It's when you decide that you have your wealth is measured by adopting the American lifestyle, which is what a lot of people do. That's when we start to see, the people that live in the cities that consider themselves more Americanized versus the people that live out in the rural areas that are living more off the land, more, more active, more taking care of themselves, resting, all the things that you need to basically rejuvenate yourself. They're having their regular rates of cancers or whatever it is. So I think that the more westernized you become, it impacts on your risk, not necessarily because of the more stress that you have from, poverty or whatever it is that we experience in developing countries, because I think that people are richer in terms of family and things that bring them joy, and they're not seeing stress the same way. What we might consider stress because we don't have it in this country, they don't consider stress because they're richer in all the other fellowships and all the things they're using, to enrich their lives. So I don't think would be a factor.
All righty.
So
Now, I'm gonna have to take control here just for a second. Dr. McDermott,
Mhm.
we have a host of questions.
Go ahead.
And this webinar is about answering questions from the community. I got to get some of these questions answered, and our time is starting to run. Actually, it's run out, but we're going to continue and answer these questions. All righty. First one, and we, you know what I mean. We're going to get through this. Is breast cancer hereditary?
So breast
Andy.
cancer most of the time is not hereditary. So only basically about 15% of breast cancer is hereditary. Most of breast cancer is not hereditary. And I think that's the biggest thing. People think I don't have any family history, I don't have to worry. Well, that's not true. Because our number one risk is being female. Number two is getting older.
But if I might inject real quick. However, it's important that the risk when it comes to genetics, it doesn't have to be the risk of a family member with breast cancer.
Right.
There are cancer syndrome where family members, for example, with ovarian cancer, uterine cancer, certain colon cancer, that does put you at risk for breast cancer. It's kind of like what Nelson always say, you need to know your A1C. you need to know your genetic risk for all cancers.
Right.
Absolutely. This is why we do genetic screening. We don't do just BRCA1, BRCA2. We do a
Right.
panel because we want to see what your risks are relative, because they're, what I call cousin to breast cancers or
Mhm.
other epithelial. So it's risk assessment encompass all of that. Totally.
Next, is breast cancer curable now with all that we
Yes.
know? Gotcha.
Absolutely. But it's
All right.
important to find it early and be in the best shape of your life so you can get all the treatment and do the work that it takes agency to prevent it from coming back.
Okay. I think we covered this real quick. What is HER2 breast cancer?
So HER2 is a marker, a receptor that's on the cancer cells. So when we do a biopsy, we evaluate the cancer cells to see if it exhibits this marker on the surface. And HER2 is one of the proteins that's on the cancer cells that tells us how we treat that breast cancer.
Mhm.
HER2 responsive breast cancer is considered one of the more aggressive type, but fortunately, we have come up with immunotherapies, things that allows our body to gear up to fight the cancer, and it's certainly curable today.
Okay. All righty. I think we've covered this, but the question came in, so I think we should go back. What is a biopsy? And who is a possible candidate for a biopsy?
Okay, so a biopsy is a test that's done to actually examine an abnormality that's seen on a mammogram, ultrasound, or MRI. Okay, so it's a way to access tissue. That's what a biopsy is. And a biopsy can be done using ultrasound to guide a needle, mammogram to guide a needle, or an MRI to guide a needle. So the candidates for a biopsy for the breast would be somebody who's had an abnormality of the breast that we're concerned that it could be a malignancy. And so we do the biopsy to either confirm or disaffirm.
Mhm. Next question. My 42-year-old daughter developed a pimple on her breast, which was painful. It broke open and drained after a few days, and also had some blood and some pus. Once it dried up, the pain went away. Is it a reason for major concern? I am asking her to get a mammogram ASAP since she missed 2 already due to lack of insurance.
Okay. Well, she should get a mammogram. What it sounds like doesn't sound like something happening in the parenchyma of the breast, but the only way to know 100% is to actually do the mammogram to see whether or not there's something going on underneath. I mean, but it sounds like it could just be like an epidermal cyst or something like that, something in the skin, but there's no way to tell 100% if you don't get a mammogram.
Yeah, Omar, if I might just add real quick, I know we focus
Sure.
on cancer of the breast, but just bear in mind that there are other entities that affects breast health.
Yeah.
And Dr. McDermott talked about something in the skin. You have eczema, you have hidradenitis, which is inflammation of the hair follicles, which can be disfiguring. You have fungus, you see diabetics, you have nipple infections, so all of which can be destructive to the breast. So I know we focus on cancer, but any abnormality in the breast needs to be brought to attention because it doesn't have to be cancer, and you don't have to be afraid.
All righty. And there was thanks, Patrick. There was a question that came in, and a statement that says cruciferous vegetables, weed in Africa are much different also or too. All right. There's a crane, Dr.
Hallelujah.
Hallelujah, you may. There's cassava leaf, potato leaf, and bitter leaf. All right, so just to let the general public know that is also in that list. Let's go on. Okay, how soon after surgery will reconstruction be recommended, or what factors would prevent it right away?
Okay, so for the most part, we like to do immediate reconstruction unless the patient has such advanced disease that they need radiation immediately post-op, and we don't want to do anything to delay getting their next treatment. And those are the only people that we normally do not offer immediate reconstruction for. Okay. So somebody who's got a very advanced breast cancer, who we don't want to have anything to delay their further treatment, we don't recommend upfront immediate reconstruction. But everyone else, immediate reconstruction is usually what we offer. And so it's done in conjunction with the initial breast cancer treatment. And the type of reconstruction is based on the individual, because everyone has different options for reconstruction. So you see a plastic surgeon. I will usually discuss ahead of time what I think your options are, but then that's determined ultimately by the plastic surgeon. And we work together the same day, where I do the breast surgery and then they do the reconstructions, not just for mastectomies, for also breast-sparing surgery. We do what we call oncoplastic mastopexy, where I remove the breast cancer, they rearrange the breast tissue and lift the breast at the same time for symmetry, so that you get back your 20-year-old breast, and at the same time you take care of your breast cancer and you get radiation. So there's reconstruction associated with saving the breast as well as with removing the breast.
Excellent, excellent. Dr. McDermott, let me tell you, so many people came up on the chat thanking you for being here and all of your knowledge. The thank yous came through enormously. I do have, just give us a quick, what should people look for? A reddening of the nipple or a mass under their arm? Tell us what people should look for to come to see you or their primary care doctor.
Okay, so the one thing I have to say is that there's nothing that gets people aware of a problem in the breast like pain. Okay. So for many, many years, we've known that breast cancer and breast pain do not go together. But I want to tell you that breast pain causes people to examine their breast. So it has utility in that people are examining their breasts and they're finding things, and which aren't necessarily referable to the pain, but things that needs to be investigated. So my thing is that do not ignore any signals in your body. Examine your breast. If you find that there is an indentation in the skin that's in one breast, not on the opposite breast, and you need to get it investigated. If you're having a nipple discharge, it needs to be taken care of. If you got a sore on your nipple that does not heal and just gets progressively worse, it needs to be investigated. If you have an area of asymmetry or a rash or something that is different, it has to be investigated. If you just have a general sense that it just doesn't feel right, then there's nothing wrong with being proactive and getting it evaluating and not taking no for an answer, because ultimately, even if it turns out to be nothing, at least you have the assurance and it gets you in for a risk assessment, it gets you in for future, that sort of stuff. So I think it's important that nothing is to be ignored.
Excellent, excellent.
Yeah, and if I might say something real quick,
Go
Omar,
ahead.
I often tell the patient, one of the simplest thing you can do
Mm-hmm.
is stand in front of the mirror with a good light with your shirt off and pay attention to the orientation of the nipple. And when we ask you to do a self-breast exam, we're not asking you to find anything. We're just asking you to become familiar. That
true.
way, when something goes awry, you're the first to recognize it.
Mm-hmm. Mm-hmm. And also check under your arms as well.
Absolutely.
Yeah.
Oh yeah, absolutely.
Mm-hmm, yeah. The last question, Doc, I'm telling you, you knocked this out of the park here. The last question I'm going to ask today is, and in doing some reading prior to this, I came up with on this, and deciding to stay flat.
Mm-hmm.
Do you tell me about this? This is something that obviously is this is what you do, but tell me about deciding to stay flat.
So that's been one of the biggest movement that's been going on now among women. So women are basically saying that my breast does not define me. And basically I'm perfectly fine without my breast. And it's one less thing that I have to worry about because plastic reconstruction is not usually one procedure. It's usually more than one procedure for most people. So even though initially some of these women might come and say, okay, fine, I want to talk to a plastic surgeon, after they've talked to them and they've realized how many steps it takes to get back to what they think they're going to get to their norm, it's going to be prohibitive in terms of lifestyle, work, or whatever it is. So a lot more women are choosing to go flat in order to be able to feel like they've regained their life in terms of autonomy, not spending so much time in whatever, and they don't feel like they need to be validated. And I think it's actually one of the best things that's ever happened and that's usually a patient decision after getting all the information. And I've seen some beautiful tattoos over these scars that, they should be proud of. And at the end of the day, it's about you know, how comfortable you are with yourself and what it means to you, breast versus you, as how it defines you as a person. And there's never any wrong answer. So I'm seeing more and more people doing that. And I welcome that for the most part.
Excellent, excellent. I'm going to say that I am so, so happy that you decided to come on and be with the brothers. You know, we try to, the first webinar of each year, feature someone who we think is exceptional. And that's why we called you here, because we knew that you were going to knock it out of the park. You did. And I trust that each and every one of the audience out there tell someone that this webinar is here. You just have to go on. We will post it probably by tomorrow. You can go on OBHealthy, just hit the camera sign or go into our YouTube logo and hit that, and have friends and family look at this webinar, because you knocked it out of the park. And we so appreciate you. Thank you.
Thank you for having me. And, you know, this is great.
All righty. All righty. Well, until next month. And remember now, I got to read my exit here. I always forget something, right? But the thing of it is that what I'd like to say is thank you to OBHealthy for allowing us to bring this webinar to you, because without them, we couldn't do what we do. And we couldn't, allowing us to use their platform. Remember, this webinar is every second Saturday at 1 o'clock. And if you want to really see our past webinars, all you have to do is go to OBHealthy, click on the doctors, and just go to our YouTube, as I stated, and all of our webinars are there. Okay, about 50 or 60 webinars. I don't know how many, but there are a lot of them, and you can do all topics, and they're all geared for people of African descent. All right. Remember, caring and sharing. Tell neighbors, tell family members, tell church members about what we do here, because it's all about educating us as a people. Please do not change any aspect of your medical care until you consult your physician. Only your doctor, and I'm serious about this, only your doctor can truly take care of you from a medical standpoint. All righty. I'm so appreciative that everybody came in this month. See you next month. And until then, I'm going to say peace. Peace. All right. Thank you, Dr. McDermott.
Thanks.
All righty. Y'all take care now. We're going to leave. Thank you.